Hello, I'm Solana Rice, co-founder and co-executive director of Liberation in a Generation. Welcome to Distancing Racism from Racial Exclusion to Radical Economic Inclusion. I'm joined by my co-founder, Jeremie Greer.
Hey, y'all.
Today, we are joined by Dr. Atheendar Venkataramani. He is a assistant professor in the Department of Medical Ethics and Health Policy at the Perelman School of Medicine and a board-certified general internist at the University of Pennsylvania Presbyterian Medical Center. He has many degrees, as you might imagine, PhD in health policy, economics from Yale University in 2009, and his MD from Washington University in St. Louis, go Bears, in 2011. His residency was at Mass General Hospital. I'm really excited to talk to him today because of his research focusing on, one, the effect of economic opportunities and the policies that influence them on health behaviors and outcomes, the effects of early life interventions on adult health and well-being, and the mechanisms underlying these links. Also the role of social policies and structural factors in shaping population health, which obviously is of grave concern right now. Dr. Venkataramani, thank you for joining us on Distancing Racism.
Thanks for having me.
Let's start with, let's just getting to know you. So why did you decide to dedicate your life and career to being a health economist, looking at racial disparities in particular?
Yeah, so honestly, it goes back to St. Louis when I was a first and second year medical student. I always knew the importance of public health, but I had been pretty focused on being a clinical doctor. But one of the things that was really fascinating and depressing, honestly, about the hospital where we were working at and training was the just incredibly stark health disparities that you would see on a day-to-day basis. So I saw more diabetics coming in with late-stage complications requiring amputations, for example, of their foot or below the knee, than I ever thought I would see in a country as rich as the United States. And it was almost exclusively Black American patients. And when you're faced with that kind of stark reality, you start to think about what is it that the health system or doctors or whoever, what is it that we're missing that keeps reproducing these same types of incredibly disparate outcomes over and over and over again. People at that time often talked about maybe genetic differences that might explain these outcomes, which there is really no genetic basis for someone to develop a late-stage complication of a disease when there's been no treatment before that. Whereas another person who has early treatment avoids that altogether. So what got people into trouble in the first place? Why were they at higher risk of developing that disease? Why did they not get the treatment they needed? What were the barriers that were put upon them that prevented really important, timely, and life-saving care? And so I couldn't ignore that. And it took me on a journey of trying to understand really the roots of these disparities through an economic lens, because through college, I was interested in economics, and I saw that the two could be put together potentially to be illuminative of all the upstream factors that produce these, I think, really unfortunate disparities I was seeing on the ground.
So the public health system's been stretched because of COVID-19, even before COVID-19, the public health system was really stretched, and Black and brown communities, whether as workers or patients, have really kind of borne the brunt of that. You recently tweeted out a series of articles about racial capitalism, and I'd love for you to talk about what racial capitalism means to you, but also like how it shows up in public health.
Sure thing. That's a deep question, and you'll get kind of a long answer. So cut me off if you see fit. So as an economist, let's start with capitalism. And I think we think of capitalism as really a system that embraces the market economy. And one of the first things you learn in an Econ 101 class is the first fundamental theorem of economics, which is that when certain assumptions are met, market economies and capitalism is the most efficient way to distribute goods and resources. In the last 50, 60, 70 years, I think more and more economists have shown that the actual economy doesn't meet those ideal kinds of conditions. And there are things called market failures. For example, a market failure would be the lack of information that we all have in making decisions, or it may be that there's a a monopoly that kind of sets wages and sets prices in ways that are not optimal. So these have been, I think, elucidated and time again as challenges to the dominant kind of market economy model. But the political responses to those forces has been uneven over time. So that's just thinking about, okay, if you have an idealized system that can work in really efficient way of distributing goods and resources, we have challenges to that idealized system. If we address those challenges, then capitalism will work for everybody. But the other fundamental thing that I think is becoming more and more of, I think people are more conscious of in the last 20 years or so, is that even if capitalism works perfectly in distributing goods and resources, the people who set the rules initially, or the initial allocation of those goods and resources, and that could go back centuries, may have been unfair to begin with. So while the allocation system could be fair even in this ideal system, which is not, because we know it's not ideal, if resources were distributed unfairly to begin with, there's always going to be a persistent set of winners and losers in capitalism. And so thinking about it as an initial conditions issue, that's kind of where I started thinking about racial capitalism. So you have a group of people that for 300 years or more have been marginalized every step of the way in US society. They never had the resources to succeed in a capitalist economy, even if that economy was functioning in the allocative way that it's supposed to. So it has been fundamentally unfair for a very long time for a large group of people. And I think increasingly people are realizing that whether or not the market works, if you didn't start out in kind of a fair way, the market is not going to work fairly for you. So that's kind of what I think racial capitalism is. We have had embedded structural racism in our country for several centuries. Given that that's the case, even if we're really good at getting the prices right and having the exchange of goods be as efficient as possible, someone is always going to lose. And historically, it's been Black Americans, Native Americans, for centuries now.
I'm so glad that you went back to say that the people that were setting the rules about how this economy would work were essentially excluding large swaths of the country and people living in the country. So I'm curious about, from your perspective, how the public health system has been shaped by some of those early decisions and has continued. How have we shaped our public health system and our health care system in a way that sort of perpetuates all of those race-based exclusions?
I think healthcare and public health as a whole, maybe in the 19th century, early 20th century, I think they were more integrated than they are now in terms of their function. And there are a number of ways in which I think these kind of structurally racist ideologies perpetuated the healthcare system. Part of it was this, I think, belief for a long time that there were people who were inferior on the basis of color or some other attribute than others. And so that belief of inferiority, which gained some kind of pseudo-biological plausibility, and I say pseudo-biological because it was not a plausible hypothesis, whether be it on genetics or some other type of biological access, that was ingrained in the public health and healthcare system for quite some time. So for a long time, people believed that people were not equal, that there was a genetic basis to different types of conditions and diseases we see. There was a genetic basis to poverty. And interestingly, capitalist ideologies masked with this kind of social Darwinism, I think doubly perpetuated these issues, right? So you could imagine that an assumption that to succeed in a market economy, the moral imperative is to be the best possible person you can be. And by the way, there are people, if they don't succeed, they lack some fundamental attribute, and here's a group of people that we think lack that fundamental attribute. So this was pervasive thinking that I think spilled into public health and healthcare. I will say, though, that public health and healthcare have diverged a little bit. And I would probably say this is after the Tuskegee experiment, which I think was incredibly consequential, both in underlining the degree of structural racism, the degree of devaluation of Black lives among health professionals, and in creating, I think, generations of mistrust in those professionals, which was, of course, entirely warranted given how horrible that experiment was. But I think public health had a number of wins. They were focused on poverty. They were focused on urban squalor. and they agitated for improvements in social conditions for poor workers in particular, improvements in sanitation and water. And these improvements as a whole, I think, for Americans of all stripes, had been incredibly effective in reducing mortality rates from preventable diseases for the first 50 years of the 20th century. And healthcare, I think, was less important in that early period than the public health system was. And there's one popular thesis that academics have. Since the 50s, and really since 1980, I think public health has been devalued, and there's been a devolution of public health responsibilities to state and local agencies, which are differentially equipped from the beginning to be able to actually carry out those responsibilities meaningfully. And I mean that in a resource sense. And healthcare has really taken, I think, the lion's share of our attention and our budgets, to the point where now we're investing in social determinants of health through healthcare organizations, which I think is an incredible flip from what we were doing in history before. And within healthcare, I think structural racism it pervades almost everything we see. Large healthcare organizations operate as nonprofits often, but there are some for-profit agencies. And in doing so, there is an incentive, or it had been an incentive, to try to take care of patients that were, quote, more well than others. And so the safety net hospitals, which serve, I think, the majority of Black American patients, Latino patients, poor patients, indigent patients, has been underfunded and kind of neglected and sort of left off to their own, while we basically reimburse the types of services and the types of patients that wealthier hospitals have seen. So that's one big wedge. And the financing streams have been really inconsistent. The Indian Health Service is a great example of something that we've typically underfunded for years. This is government healthcare for Native Americans, and the facilities vary greatly in their quality, but in general, we do a poor job of taking care of the population health problems in that population, even as we have a really well-functioning Veterans Affairs Administration that's also taking care of a niche population. So I think that the types of healthcare institutions that serve different populations have diverged over time. The way we've paid for those institutions has diverged over time. Only recently have we thinking about how do we incentivize healthcare organizations to think about population health as a whole, through giving them larger budgets for which to try to improve population health outcomes by creating incentives for prevention. But all of that is in the last 10, 20 years, after, I think, decades of reinforcing this dominant model, which has favored some population groups over the others. And all while public health spending has declined and has left us vulnerable to these incredible types of threats that we're seeing now.
What I love about what the connections you're making is around the way that our society values Black, Indigenous, immigrant life, and the choices that we are making as a government in our public sphere. And so we know that in the current, because of the advocacy of a lot of groups, we know that Black people are 2.5 times more likely to die of coronavirus. Native Americans are 1.3 times more likely to die of coronavirus, not to even mention the disparities in infections. And that these outcomes, and what you've kind of laid out, is these outcomes don't happen by accident. They come by choices that we make. And I wonder if we zone in on this current pandemic, what are some of the economic choices that we've made during this pandemic, or even preceding the pandemic, that has led to the disparities in the number of people of color dying and contracting coronavirus?
That's a really great question. I will say that for those of us who've been studying this for some time, early on in the pandemic, our fear was that coronavirus would fall hardest on minoritized populations. And it was sort of sad to see that happen, but also sad to see that people were surprised that it happened. But going to your question, there are a number of interrelated trends, and we can start back to the Reconstruction era, right? So right after slavery was abolished, there was a window where there was a lot of energy around providing private property to freed slaves so that they could have a fair start in America. And that basically in the Johnson administration and thereafter, that did not become a reality. So the proverbial 40 acres and a mule was never provided. Not only that, there was severe restrictions on participation in the political process. There was fear-based campaigns, for example, through lynching all through the Deep South that I think really prevented Black Americans from getting property, from innovating. So there's an incredible paper by Lisa Cook that shows that where there was lynching, there was actually reduced patents from Black inventors. It just basically snuffed out innovation, which is to the detriment of all of us. So you already have now a group of people that lacks wealth. And we'll talk about Black Americans here, but I think there are parallels to all the other groups that you mentioned. So that's a starting point. During the Great Migration, people left the South to come to the North, but we saw that in a beautiful historical study that Elora Daranancourt at Berkeley has done, that Great Migration didn't actually improve economic mobility for Black Americans. So people ended up being worse off after migrating, and part of it was the kind of racialized response to that migration. So where there was more migration in northern cities, you saw actually an increase in policing budgets, right? And something that we've been talking about more recently. So these things all have their roots going back even before 1940. So that's setting the stage, right? So here's a group of people, they have lacked political rights to make change, economic resources to achieve upward mobility. Moving didn't even help lead to upward mobility because of the responses among white elites in those northern cities. And so you have the Civil Rights Act, Civil Rights era with Lyndon Johnson, which I think was transformative in a number of margins in terms of access to health care. There was an increase, there was a decrease in the wage gap between Black men and white men. And so reducing discrimination in that era was incredibly helpful. But if you compare to 1950 to today, the wage gap between white and Black men today and in 1950 is exactly the same. So after a period of narrowing, it opened up again because of a number of policy choices that were undertaken that I think cut people's legs out from underneath them. A big one was incarceration. So with that mass incarceration, there was a reduction in economic opportunity for Black men in particular, and there was a destruction of Black communities as a result of that. Other forces that we've been talking about, namely with the opioid crisis, were important too. So in the 80s, there was massive deindustrialization, which actually, the first kind of narrative of deaths of despair was by William Julius Wilson, and he was talking about Black men and Black women in inner city metro areas. So the wave of plant closures in the early 80s and late 70s and early 80s actually destroyed the economic status of Black men and women in these communities. Suburbs were not friendly for people, so there was little ability to move out of it. Then came federal mass incarceration, then came the HIV/AIDS pandemic or epidemic. So these economic forces, coupled with the pre-existing, I think, economic trauma of structural racism, have created effectively a secondary class in the United States that's occupied by racial and ethnic minoritized populations. So you come into COVID, you have a group of people who are living in neighborhoods that lack a lot of resources because the tax base is not there, the investment is not there, the public goods are not there, dilapidated housing, people working in really jobs that are low wage and have the lack of economic mobility to leave those neighborhoods. The types of jobs they have involve interactions with lots of people. They can sometimes be exploitive. And so that's the perfect setup to contract a really scary infectious disease. And again, we can walk all of this back even right well before Reconstruction, but none of the policy choices that we've made, save the Civil Rights Act really, I think have have made a dent. And if in some cases, I think we've reversed some of the gains we made during the civil rights era through the policies that were undertaken from the 1980s onwards. So yeah, with all that, it's not a surprise that you've basically seeded the risk factors for this disease. And in some ways, COVID is it's a perfect storm that just throws into sharp relief every single bad policy choice that we've made in history.
And hearing that history, it seems like this isn't going to be the last time, right? We're going to see other outbreaks of illness like COVID-19 again. And it seems, and I'd love you to respond, like, if we don't do anything different from an economic standpoint to change the trajectory, we're just going to repeat this all over again, right?
Yeah, I think so. I mean, in some ways, we are repeating it all over again with COVID. So we see that in natural disasters, like with Hurricane Katrina, versus natural disasters in other areas, like in Florida, the type of response that we have and the destruction that follows unevenly on Black Americans versus other groups. If you want to talk about, I think, an epidemic disease that has hurt Black Americans, let's talk about the slow burn of cardiovascular disease. Like the death rates from cardiovascular disease, conditional on age and even education, are far higher for Black men and women than white men and women. Maternal mortality is higher among Black mothers. Infant mortality and birth weight gaps remain between Black and white women and their children. So COVID really is the latest in, I think, what has been a series of similar situations. Just they've gone on in a slow and maybe unnoticeable way to people. This time you can't really ignore it. I think in the same way that you can't ignore police violence, like the way George Floyd was killed. It's just in your face like that.
You have given us an illustration of what we call the oppression economy. It's one where racism is profitable. You've spoken to the decisions that elite, mostly white-led organizations and institutions really using tools of theft, exclusion, exploitation to expand power, wealth, health. I'm curious from your perspective, if we're to move from our current economy into one where we call sort of a liberation economy, what policies do you think should guide us to both a better economy and a better public health response?
Yeah, I think it's a great question. One of the things that I think we've learned from universal policies in the last 3 decades is that there's some basic things that can help everybody that often have the effect of really helping minoritized population groups. So something like Medicaid expansion, minimum wage increases, the earned income tax credit. These are all evidence-based social policies that can narrow racial gaps in health and economic outcomes over the life course. So there's a lot of things that we could do that we already know about. I think, though, universal policies will only go so far because that wedge and that force of history remains that in some sense is not really affected by that. So there has to be, I think, intentional attention paid to wealth gaps between Black and white households, for example. So I think this is where conversations about innovative social policies, and I use the word innovative in the sense that not that someone just thought of it, but that we haven't really tried it. But innovative policies like baby bonds, perhaps reparations, perhaps basic income grants, these types of things are worth thinking about as well. So I think we need to think about what does the evidence show in terms of social policies that we've already tried. Some states have tried them, others have not. How do those affect people differently, and how do those narrow racial gaps? It turns out there's a whole suite of things that we already know how to do that if we did in a potentially larger way will create more economic and health equity, and potentially can create more efficiency as well if people are more productive as a result of those policies. And then we have to think about how do we, as best as we can, address the force of history. and what are the public policies that might do that. And that's where being intentional about gaps that have been really hard to close, and wealth in one is particular. I think that's where we need to get creative and have some courage. But lots of people have studied these things, and lots of people have put forth proposals. And there's the nice thing about this is that I think this is a moment where most Americans agree that structural racism is a problem. So historically, I think this is new for me. I mean, I'm 40 years old, but it's new for me anyway. 40 years is a long time. So I sense that there's an opening here. And there's also, we know that there's more support for policies like Medicaid expansion, right? Like that Oklahoma just undertook. So there's more of a political consensus around the problem that there's a specific issue with the way race and ethnicity manifests in outcomes for different people and their flourishing, and that there's specific policies that we know for everybody are good. So if we can take this new intensity and new support around structural racism as an issue, can we add to this policy set new ideas like baby bonds, reparations, income grants, and so forth? So I think this is why your organization is amazing, because it's coming at a great time where you can leverage this energy, and there's a lot of evidence around what social policies work. So I guess it's more of we just need the courage to do the things that we already know we should be doing. There are other things that we should think about. You know, my wife and I struggle with this decision of whether to move to a suburb. We live in Philadelphia right now. So moving to a suburb would mean our tax dollars go to the suburb, and the way we fund schools is such that it's fully based on local tax dollars. And with COVID-19, I think this is another moment where we're seeing that schools that are less resourced are going to have a real problem with distance learning, and low-income families are going to have a real problem with distance learning, and nobody wants to harm kids. So is this an opportunity now to think about how we support schools in neighborhoods where the tax base has been historically low, and we don't actually provide the inputs to learning that are necessary, and the quality teachers that are necessary, and the support to teachers that are necessary to let that next generation flourish. So there are a number of these wedges. I think we have an idea of what to do. There's been political barriers to doing it, but maybe some of those are disappearing.
Our final question, Dr. Venkataramani, what's giving you hope right now? What's giving you life? It sounds like this is a window that's giving you energy. What else?
Yeah, I mean, honestly, I think it's, I'm just seeing a lot of empowerment among people. I'm seeing more people speak up who otherwise may not. And I'm seeing people who are listening who may have not been listening before, and they're listening in different ways. This is, I think, a generational project, which is why I love the name and the kind of the focus of your organization. But I think in a generation, it can happen. There's just more engagement with ideas that were uncomfortable to people, or people were immediately able to cast aside. You know, I think about this article. This is from some work I did on Mexico and diarrheal diseases. And there was an article that I had read when I was in graduate school called The Paradoxical Benefits of a Pandemic, of the cholera epidemic, which was in the 90s in Mexico. And as a result of that, there were a bunch of technocrats in government who decided that, you know, we don't want cholera in our country, so we're going to just chlorinate the nation's water supply. And in doing that, over 5 years, they saved something like 15 to 30,000 children. But that was just one of many paradoxical benefits. They took proactive steps in the face of what could have been a calamity to really create change. And those kids, we've tracked them over time. They perform better on test scores today. They make higher wages today. I mean, like, that is really a generational change, but it happened because some people had courage and they took that window of the opportunity. I think people are talking like that now. I hope I don't watch this in 5 years and just shake my head at how naive I was. But like I said, I'm 40 years old. This sounds a little different to me. So I'm gonna keep pushing, just like you all and everyone else.
That's fantastic. Thank you for your time. It was so illuminating, and take good care.
Yeah, thank you. This was a lot of fun and very important work.